Thank you, ATHS. Thank you for continuing this morning about cannabis. We're going to start very quickly so we have time to discuss together. We have until lunchtime, until midday. I want to thank Professor Georges BROUSSE, who's Professor of Etiology and Psychiatry at Clermont Ferrand, and who is going to begin by talking about BDA. And then we will hear about Romain ICICK, who is at the hospital in Paris, in northern Paris. In Paris. And who is going to talk about the toxicity or vulnerability of BD, and we'll also talk about the practical care with Professor DERVAUX, who is Professor of Psychiatry at the University of Paris-Saclay. George, you have less time than expected. I'll stop you when we get to the end. Thank you, Amine, and thank you, everybody. Thank you, Jean-Pierre ATHS and ATHS for asking me to speak about this question, the link between cannabis and BD. Well, why this question? The question has come from the news. The death of Sarah and me was in the papers. We heard that the assassin was suffering from BD and had cannabis. And so the question is, was he responsible when he committed this act, and how to characterize the psychiatric disorder? These are questions which we wanted to look at this morning and share with you. The context: we are in a country where there's a lot of cannabis which is consumed. You all know the figures. And it's not with those who, we're not going to look at those who experiment with it, but at those who consume it. Those at high risk, and which represent 2% of consumers. These consumers are not necessarily aware of the problematic usage of this. And delirious puff, or BD in French, we'll hear from about accounts of patients. And I heard from a patient who was 17 years and said since he's had it, he's been hearing voices. And the cannabis can be related to BD. And what is this? Delirium is the basis of this morning's discussion. The dictionary definition is very good. It's a psychiatric disorder of somebody who has lost contact with reality. The clinician, you know that it's not confusion. It's loss of contact with reality. The person perceives things, says things, thinks things which they don't understand, which are not related to reality. For example, hallucinations, which are often voices. I haven't heard any voices, because I haven't smoked yet. The notion of BD and its relationship with toxicity. Mignon, who was a French psychiatrist at the end of the 19th century, described this as something that's very brutal, happens very suddenly. People smoke it, it's polymorphous, it goes in all directions. But the idea of Mignon is something that comes, it leaves very quickly. Historically, this is one of the toxicomanic psychiatrists, and who's written a great deal about toxicity of alcohol, which is interesting. It says there's quite a lot of deliria, things that are very often instant, and what characterizes this is the sudden appearance of like a thunderclap. That was the idea. It's something very surprising. It comes out of nowhere. Morteau is also one of the French doctors who, let's say, thought about the taking cannabis. Both say this in the BD. There's something that starts it off. There's like an original experience we see in patients, perhaps a triggering event, and these are hallucinations. They feel that their personality has been transformed, and what's particular is that it's something that is present in cannabis takers. So it's suddenly in a very serene situation. It's like a clap of thunder, and the historical aspect, it's disappeared throughout the 20th century, and there was a novel which brought this back into the spotlight, the evolution of the disorders. And when we can see the evolution with patients who have all kinds of deliria. They have, it comes and it goes, and there's a type of intermittency, and it evolves towards a pathology. So the idea is that it evolves or not, because it's so polymorphous that it's very difficult to come up with a very precise description. This is between two levels, between maniaco-depressive, for example, changes in humour, and deliria, which are more confusional, as where, for example, they are confused in space and time, and it's between the two. We shouldn't confuse confusion, but the BD is more maniaco. And in '87, they organised the between 20 and 40 years old. It's always without psychiatric previous, and there's no chronicity. It comes in and it goes, and sometimes there are no anomalies in the intervals. And as one of the criteria, it's delirious ideas. The aspect of a doubling of the personality, no abnormal feelings, sadness, and clinical symptoms which vary greatly from one hour to the next. In '87, he described it shouldn't be linked to alcohol. It should only be linked to the to substances, and it's only progressively then when you can feel the difference between consuming substances and BD. It's a difference which was perhaps not noted by BENYAMINA and by the historians, but we can see in the 1980s. We can talk about BD if there's substances that are consumed, and outside of the consumption of substances, certain individuals it's the classical case, the military service, and the BD of young soldiers. It comforts the carer when you're an intern and you've never been confronted with this. It's you suddenly have a patient who's got what's marking is this. It's a crisis which is non-resolutive and puts the patient under threat. The Americans highlight transitory acute disorders, but what has to be noted between the BD as we see in France and its international classification, the international classification focuses on diagnosis, and they have excluded elements, parasite elements, are leaving us which many clinical aspects on duration and time restricted. We can see BD brief psychotic episodes are BDs, and you can see that the, substances can lead to delirium. The Americans is mother in psychotic disorders, and psychosis is due to taking substances. The substances I've just described is historic. So you have delirium and confusion, large confusion with cannabis. There are hallucinations, and people say, I can see things, I hear things. It's not normal. It's linked to linked to the consumption of cannabis. So they have metacognition of their state. And what has disappeared, and what we forget, is a state of delirium produced by taking cannabis, where the patients aren't aware of this. And here, the substance is intimately linked to asymptomatic symptoms. Our patients can have a BD episode. The model of vulnerability was described by Azoran, and we also have disorders of the personality. 63% of BADs, and DSM-5 works on this. We could consider that patients at a very high risk of psychosis could be the patients on cannabis. There's a larger risk. Is it toxic? Is this a factor of induction or a consequence? This is a true question in the dual disorder of cannabis and BD. We'll go quickly through this slide. If we look at the disorders, we can see we can have delirium about substances, but not the opposite. And toxicity is not present, is not visible. There are two tables of exposure. We have toxicity, which leads to psychosis. If we take away the toxicity, psychosis disappears. We could imagine that taking cannabis leads to psychosis in an individual who is already vulnerable. And there's a certain number of works today which show that an vulnerable individual, patients who have a childhood disorder, are more likely to develop when taking. You can see the blue arrows here. In premorbid patients with vulnerabilities, they are more likely to have to suffer from deliria. What type are these BDs? The classical description is: this is what we're told, this is what we know. Half will be cured. 20 will take it again. And 50% will evolve towards schizophrenia. And we know the link between cannabis and BD and schizophrenia. So a number of studies have shown the chronic pathology of many studies. The more it's consumed, the bigger the risk of delirium and schizophrenia. And the younger that you consume, the more schizophrenia with hospitalization, which is more and more frequent. At the beginning of the illness, we can see that the state of schizophrenia would, in the beginning of the illness, we see a percentage of cannabis consumed, which is very high, especially in young men who are at the start of their schizophrenia, either in psychotic state, brief psychotic state, and these are big consumers of cannabis at the beginning of their illness. The meta-analysis showed that the consumption of cannabis increases the risk of beginning schizophrenia through an acute schizophrenia. And from 2007, we can see different parameters. Moore says the different parameters, and tries to see if cannabis really influences this. And we have another element which is important is the recent meta-analysis from 2005 or 2010 or 2020 shows in different studies the fact that consuming cannabis can trigger a psychotic incident and how has this evolved? These psychotic episodes evolved. These patients who who have brief psychotic episodes, there's a study that was carried out by BENYAMINA, which is accessible online and which looks back at BD. In this paper, this subject by Hunt shows psychotic studies which show that around 1 out of 2 on cannabis will risk schizophrenic episodes. Then there's later a meta-analysis of all of this consumption and schizophrenia, and we have 25 to 30%. Perhaps because we the others are atypical procedures. And who's responsible here? What's responsible here? We don't have a lot of time to solve this. A meta-analysis on the studies looked at healthy subjects of TH or cannabidiol. THC leads to a positive delirious, but the motivational pragmatism of schizophrenia and general symptoms of schizophrenia, cannabidiol can reduce these symptoms, but of course all of that still remains to be proven with further studies. To conclude, I'd simply like to say that we could perhaps ask the question before in young subjects, the psychotic experience exists in young people. There are not many studies which have studied the consumption of cannabis and psychotic episodes in young subjects. A Spanish study tries to show the relationship with young psychotic experiences in teenage years by experimenting with psychotic substances. This shows that the episode is short. It can lead to schizophrenia more often than BD, leading to schizophrenia more than 50%. And there are elements which favour this important high consumption and stress and traumatism. Thank you.
Merci beaucoup.
Thank you. I suggest we take the 3 speakers one after the other, and we keep questions for later. So I now give the floor to Romain ICICK. The room across is ready. So if you wish to join that room, you'll get sound and image. You just have to cross that door, and it's an air-conditioned room. It's nice, clean. Okay, so let me introduce Romain. He's a psychiatrist and an addictologist in Paris, and he's going to talk about the subject of toxicity or vulnerability of cannabis and BDA. Thank you. Good morning to all of you. I'm happy to be back here at ATHS, and of course, happy to be here with my mates on the podium. So the subject is toxicity or vulnerability of cannabis and BDA. That's quite interesting. We don't know everything about the subject. A few disclosures, but this is pretty old. Now let's check the outline of this talk. I'll talk about vulnerability and its concept. What can we conclude with epidemiology and clinical findings? What can we say thanks to neuropsychology? And what can we say with genetics? We've had some recent advances. It would be a pity not to take advantage of this. So, cannabis and BDA in PubMed do not appear. BDA is French for acute delirious puff, ADC, sorry, ADP. So I checked the other words, other keywords like psychotic experience, etc. So this is just to tell you that there isn't much on the subject, and this is why we are here. So vulnerability is the likelihood of developing a disorder. So it's indeed a mirror of resilience, and resilience is something we're not very good at. Resilience is also resistance to develop disorders despite risk factors. We don't know much about the protective factors. Of course, there is a continuity between normal experience and psychotic experience. 25% of the population may have psychotic experience with cannabis or just because of sleeping disorders. So acute delirious but do not account for that, and for psychotic puffs, things are not very much understood. Trauma and stress also appear as a risk factor, and resilience comes in now. And as I told you before, we really lack data. So cannabis and acute delirious puffs are associated in the general population. I just have a prospective study. In a large cohort of several thousands of subjects in the Netherlands and the neighboring countries, an assessment of psychotic behaviors was made, with also an assessment of the use of cannabis in these subjects. So things seem to be associated. We don't know about a causal effect. It's like a dose-response effect and the prospective aspect. It seems that cannabis users, in fact, show some productive symptoms. This is just an observational study, of course. It seems that if you smoke more, you are likely to have psychotic events, and if you don't smoke or smoke less, you are less likely. So, another study now, 16 participants were recruited in recreational consumption use, and then they were checked in terms of symptoms with THC alone, or with CBD, or with placebo. it seems that CBD, of course there are ongoing studies on the subject, CBD seems to restrict the psychogenic effect of THC, and placebo didn't give rise to much psychotic events. I also checked data for bipolar patients. Those with disorders related to cannabis might have bipolar bouts, and this is quite interesting. If they have more of these psychotic events with the use of cannabis, it could be interesting to check if this is true. In that case, we have a p-value which is very small. It's p minus 6. So in this study, the numbers do not seem to be very different with or without cannabis-related disorders. But the effect is quite significant here. The size is too small. It's 0.9. But if we adjust with other important elements like age, gender, or bipolar disorders, you lose this association. So cannabis appears to be more maniacogenic rather than psychogenic among bipolar subjects. It's still quite interesting to note. Our team published last year a survey, a network survey called PsychoCo, with 180 patients with cocaine disorders. So they assessed the productive symptoms induced by cocaine. So can cannabis induce more psychotic events in cocaine users? You know that already quite a lot already have these effects. But now this study shows that cannabis has increased delirium. And probably this is related also to the diagnostic of schizophrenia. So if you are already using cocaine, you don't need to have cannabis to get an even bigger delirium. And in bipolar patients, it was also the same. Nothing really better or stronger with the use of the two substances. What about neuropsychology and biopsychology? If we take a look at studies that consider the brief psychotic disorders, well, the psychotic patients seemed to have the same amount of events as the control group. So that's quite interesting, but these brief events or disorders, psychotic disorders, are not a pre-morbid condition. It's really the current state at the time when patients were assessed in the survey. But they seem to have better, I would say, functionality of the brain. So I have been using the neurocognitive models for psychotic symptoms, productive psychotic symptoms, such as disorders of self-conscience, difficulty of the theory of the spirit, and disorders of the internal speech. This could be related to a neuronal noise. Now, what about the effect on THC on this? For self-consciousness, indeed, it seems that cannabis and self-consciousness shows indeed a relationship. As to the so-called spirit theory, of course, there are different scales that can check this. It seems that indeed this was the case. And for the internal speech, also indeed cannabis changed that. This is obviously a distribution of the salience of stimuli. It's not a question of striatal dopaminergy, but I can tell you it's not that very simple. In fact, internal stimuli as well as internal ones may have an importance in terms of self-consciousness. So this is what cannabis would do, that is, that would change those stimuli. As to experimental conditions for surveys, there is indeed a decoupling of the intensity of symptoms. Cannabis gives productive symptoms to nearly anyone. And when you get the actual levels of dopamine produced in the brain, this is not normal, actually. This is not obvious. The effect of cannabis on dopamine are not understandable. David Nutt, who is a British researcher, published radiological surveys with MRI in humans, and they show the release of dopamines after smoking cannabis. Nicotine also has the same effect, but dopamine is the addictive substance. But it creates a lot of psychotic symptoms. This may be also dose dependent, of course. Here, for example, the production symptoms were measured and seem to be higher than with amphetamines, for example. So we don't understand that. So nothing is simple and nothing is just related to dopamine. In particular, childhood trauma can also be related to this. And more particularly in young boys. Also, there are disorders in glutamate and GABA. And we also have seen some normal mutations, but no loss of function of the gene. But in people with an accumulation of these elements, there are candidate genes. They seem to be highly dopaminergic, and that could be associated to the relationship between cannabis and psychotic disorders. But the effect of cannabis on dopamine, brain dopamine, that cannot explain for psychotic events. Now, what about genetics? I'll be clear. The genetic signal is quite small, not to say absent, in psychotic events. For schizophrenia, we've had major advances over the past few years. Several millions of polymorphisms have been studied compared to control cases, and we've obtained several hundreds of signals. And the conclusion is that there are brain excretion genes that probably work with the synaptic development, and they have different expression patterns. Now, nothing for psychotic experiments. In a study by the Americans, we have at just one case. So on the one hand, we have several hundreds of signals, and on the other hand, it's normal. And this is why we're here. Is there a toxicity or a vulnerability? So on the left-hand side, we have the signals for schizophrenia, whereas on the right, we only have three little cases. This is what we call a Manhattan plot, because it's like the skyline, actually. Full genome studies are not interesting to study gene per gene and polymorphism, but it can also be interesting to check whether it is related to the brain or is there a polygenicity. We may have thousands of polymorphisms which may be together in the same individuals and favor disorders in the same environment, in the same type of environment. On the right, you have psychiatric disorders, psychotic disorders in adults and in adolescents. This diagram shows how disorders can be shared. Well, obviously, between psychotic events and schizophrenia, there's nothing in common. They do not share the same genetic signals. So if someone has tried polymorphism and cannabis, it seems that there is no effect. Besides, if we take all the effects of the genes tested, and if you have a polygenic score, a risk score, you can, in fact, import and export data. It's pretty easy. And you can see then that the higher genetic weight for schizophrenia, the higher the productive symptoms. So that's okay. This is quite fine, actually. This is quite reassuring. The more cannabis you smoke on a daily basis, again, this is quite reassuring. If you really smoke heavily every day, you get more psychotic symptoms. And interaction is not non-existing, in fact. Curves happen to be quite parallel, and the increase related to the genetic risk is the same. So there's no interaction. Whether you smoke daily or not, the genetic weight of schizophrenia favors psychotic events in the same way. So we do lack studies on brief psychotic disorders, but we can consider a high toxicity. We can also see the mechanisms. Even if dopamine cannot explain everything, we can also consider the dose level effect, which is quite obvious and not linear, but still. And as to vulnerability, we still have no information, no genetic background, no neurotransmitters maybe, and maybe in brief psychotic disorders that happen to be bad, there may be indeed some vulnerability. We can also have Mendelian studies to check the various associations. Well, actually, it's the weight of, genetically speaking, the weight of schizophrenia that can favor these brief psychotic disorders, but if you smoke cannabis, this may be even worse. So that's important. And the role of resilience is important. The dose level of THC, the way in which consumption is done, anxiety, sleep, stress accumulated over life or over the past days can also probably play a role in the individual variability, much more than the genetic variability, probably. So my answer will be that it's a question probably of both toxicity and vulnerability, but for THC and psychotic events, brief psychotic events, it's more in favor of toxicity than vulnerability. Thank you, Romain. We continue with Professor Alain DERVAUX. So you have 20 minutes max, so that we have time for Q&As. Thank you. Thank you, first of all, for this invitation. A lot has already been said, and I'll try to take another route. What can we do in practice for cannabis smokers and acute delirious puff or brief psychotic disorders? Well, what should we do? In practical terms, there are four major situations we may have to face, in particular in the emergency units of general hospitals. So we may have psychotic symptoms, not disorders, symptoms induced by cannabis. Then we may have psychotic disorders induced by cannabis. Third situation, cannabis and first psychotic events. And fourth case, exacerbation of psychotic disorders in cannabis smokers suffering from schizophrenia. But they don't necessarily tell you that they are being followed up for 20 years, and they have been followed up for 20 years. So I will briefly consider the management of these patients. So let us consider psychotic symptoms induced by cannabis. These subjects are free of any psychotic disorders, and we have the so-called paranoid effect that you described just before. This is characterized by delirious ideas of persecution. That is, those people who consider that any person looking at them wants to exclude them from whatever group. So this is also associated to depersonalization. They have the feeling that they are like in a dream, and this is quite anxiogenic. This also follows the curve of THC consumption. Usually it appears 1 hour to 1 hour and 30 minutes after the beginning of consumption, and it may last for hours. This had already been described ages ago, more than a century ago. And this was the man who described that kind of thing. And this was demonstrated experimentally with pure THC, nothing else but THC intravenously. So clearly, in sound subjects, the injection of delta 9 THC at 5 milligrams induced schizophrenic-like symptoms. I'm speaking of symptoms, positive symptoms, and for example, the possibility to read in one's mind, and they disappear 200 minutes after injection, so it's totally reversible. This is why it's a symptom and not a disorder. And then there are also negative symptoms with the lack of self-confidence, etc. And there are also cognitive symptoms, that is memory disorders, disorders with speech ability, etc. So these symptoms disappear once THC is eliminated from the body. They disappear spontaneously. So we may have these people presenting at the emergency department, but they need no treatment, or maybe a bit of benzodiazepine, but it usually disappears spontaneously. Besides, we also have psychotic disorders induced by cannabis, but in that case, they're not just symptoms, but they're really disorders. That is, that they last longer. So this is what CSM-10, this is what is going to be considered as CSM-10 in French hospitals. So this is what is called pharmacopsychosis, and which is now called cannabis-induced disorders. It's the set of psychotic disorders that appear immediately after the consumption of a psychotic substance that can be explained by an acute intoxication, and which is not part of a weaning strategy. And this is characterized by hallucinations, whether auditive, but generally polysensory hallucinations. A distortion of perceptions, particularly in the evening or at night, where you have the feeling to have threatening figures appearing in the curtains or whatever. And last, we have those delirious puffs, placing the blame on someone in particular, or believing that the police is somewhere in the staircase. And this goes along with persecution ideas. And this is why these people are very often agitated and are directed to the emergency unit. They may also have some mystical religious types of delirious puffs. I'll give you an example. I had a patient brought in by the fire brigade with some friends. He's been smoking cannabis since the age of 15. He left home because of repeated conflicts. He's always in trouble with the police because of the use of cannabis. So he left home at the age of 15, lives with friends, and of course uses a lot of cannabis and ecstasy over the weekends, particularly during festive events. You have to consider that among cannabis users, you also have amphetamines along. So in the hours following consumption, he presented with agitation, behavioral disorders, and he doesn't remember exactly what happened, but his friends told us what happened, and he was convinced that there were people angry at him. He felt that people were all looking at him. And in the beginning, he felt he'd been raped, which, of course, is the mirror effect of some concern about his sexuality. So he was hospitalized for some time, and symptoms disappeared after the treatment with conventional antipsychotic drugs. But we have no follow-up with this patient. Now, in this subject, a certain number of surveys have shown that those that have psychotic disorders induced by cannabis are usually hard smokers. 12% in, I would say, plain subjects, 45% in abusers, and more when you get to different degrees of dependence. So it shows that things are worse in strong or hard consumers. Then George mentioned the Scandinavian studies. Now, registries are quite interesting. Whether in Finland, Sweden, or Denmark, everybody with a social security number is included in a register where the diagnostic is reported. So the design of their studies is always the same. You take time T. At time T is the time when diagnosis was set, whether time of hospitalization or any other time. And 10 years after, or even more, you can still through this number find the later diagnosis. So through these registers we can see what has happened, what was the outcome of these patients when they were hospitalized with the psychotic disorders induced by cannabis, and 30% of them have a later diagnosis of schizophrenia. In other words, we have to be careful with this, and the remaining 60% we don't know actually. So it would be probably quite interesting to know. It seems that there is a question of, I would say it's a question of toxicomania. And they develop personality disorders rather than other disorders. So these subjects all deserve to be followed up. Now, what about the relationship between cannabis and the first brief psychotic disorder? Now, you are all familiar with this graph about the evolution of schizophrenia over time from childhood to the adult age. This is the natural evolution of schizophrenia. So it starts as a prodrome slowly until the first episode, then there is a remission because of treatment, then a relapse because the subject doesn't take his medicines, and then a stabilization. So the first episode appears there, and most surveys have shown that the consumption of cannabis starts usually before that. So there must be a bias. Cannabis clearly is said by several meta-analyses to be a risk factor, increasing psychotic risks, the risk of psychotic events. But this doesn't mean that it's a causal effect. That was the question that was raised yesterday in a previous session. So it probably increases the risk a little bit. But still, this represents a few thousands of people. So this paper was quoted yesterday by Pierre. There are many more studies of the same kind showing a clear increase of the incidence of psychotic disorders, and in particular schizophrenia, in a large number of European cities. But this increase remains small. So, of course, risks are increased, but it's not an increase with a huge effect. So I did this little diagram to explain this. If cannabis was psychotizing, there would be many more schizophrenic subjects. In fact, this is not something that we can see clearly in terms of public health. On the left here, let's take, for example, France some 20 years ago. We had a few cannabis smokers, and in red we have the frequency of schizophrenia. In short, it's between 0.8 and 1%. Now, when you increase the consumption of cannabis in the general population, much more cannabis consumption these days as compared to the non-consumption of cannabis, schizophrenia increases as well, but very little, just from 1% to 1.8. So you don't see it in terms of public health, but for a psychiatrist it is important because it represents several thousands of patients. So cannabis can be indeed an element that triggers a decompensation in some people that might not have had these kinds of psychotic disorders if they'd not been smoking cannabis. So if you have a subject with a first experience of a psychotic event, what is important to look for? That may be important in terms of prognosis. First of all, dose effect. The more the consumption, the higher the consumption, the higher the risks. There is indeed a dose effect there, and it's an exponential relationship, or relation rather. The more you consume, the higher the effects. This has been shown by most studies, and this is quite exponential. Second, the risk increases in subjects that started smoking at the age of 15, and the risk is also increased in subjects with a predisposition with, for example, genetic markers. But it means that you have to ask the question, do you have in your family people with psychotic disorders or schizophrenia, etc.? And then, in case of childhood trauma, like sexual assault, these disorders are further increased. So these are the questions that you want to ask when you have a patient consulting for the first time. Do you smoke a lot? Did you start before 15? Do you have schizophrenic subjects in your family? And have you had any childhood trauma? And the more you have, the higher the risk. This is quite clear. One more point which I didn't mention. The higher the rate of THC is high, the higher the risk. And this is just to show the risks with resin, not with herb, but in resin used by the youth these days. The rate of THC is about 25 to 30%. That is 4 times more than what their parents used to smoke in the 1920s or the 1980s, sorry, or the year 2000. It's much higher than what their parents used to have. So, who's familiar with this? This is the consumption in Colorado, where cannabis is legal. So they have tutorials in Colorado that you can find on YouTube where you can produce that wax, which is 90% THC, made from cannabis sold from the shops, and it's very easy to do. And these tutorials are now translated into French, so we may expect this kind of thing in France soon. And then you have synthetic cannabis like spice, etc., that people or K2 that people can find. The risk can increase. And one last point is the exacerbation of symptoms in patients with schizophrenia. You don't know when you see these patients in the emergency department, they don't know that the patient has been already followed. And clearly, it's the same with the Sousa.
And this shows delirious experiences in subjects, on normal subjects, the impact of THC in schizophrenic patients is clear. They don't take their treatment because they prefer treatment. In the short term, they prefer cannabis. The exacerbation of the symptoms of cannabis comes afterwards, after consumption. They consume like everybody. It makes them laugh with their friends, but it's afterwards, several hours afterwards, that they have their deliriums. And there's more of a risk of suicide. So what can we evaluate? We evaluate in subjects who don't have any antecedents, anything that can alert with symptoms which may make us think that they could have a psychotic incident, unblocking thinking, not in the idea of persecution, but sometimes ideas that people bear a grudge against them. And it then becomes more and more frequent over time. And for this, there are questionnaires. There's the CAMS, which was used a lot in France. And others, the SIPs. What we'll also evaluate is associated addictions, which is very frequent. There's cannabis, alcohol, and of course tobacco. And whatever the case, whatever the situation, for the 4 clinical situations I've described, in any case, the care is going to be integrated. Why? Because many patients have a dual diagnosis. They have a psychiatric and an addiction diagnosis. So they'll be treated either by psychiatric services or by addictology. And then there's the famous hot potato syndrome. So we'll have to see. All the studies show that ideal care, in theory at least, is integrated. It's the best thing, and this is what it looks like. So according to the stages of motivation, it includes addictology and psychiatric care at the same time, perhaps not by the same person. The idea to have an addictologist and who will go to the psychiatric ward and vice versa. The different stages. I don't have to tell you what these are, and this we find these in subjects with psychotic troubles. They don't want to receive treatment. There are lots of things, but we can do lots of things for them. And after, it's the classic diagram until the 2000s. I've just got 2 minutes left. On the most important elements, these are things that we often forget. Integrated treatment includes other associated addictions, and especially tobacco, because tobacco, the addiction to cannabis, always goes, at least in France, 99% of subjects dependent on cannabis are also dependent on tobacco. So if we look at weaning, then it's important to take this into consideration. Secondly, it's not necessarily hospitalization. So when you go to accident emergency, they don't realize the seriousness, but it can be a follow-up in a daycare center, which is better accepted by patients. Thirdly, there's the tools, all the tools for the motivational approach, which are there are now scales like this one to explore the motives for consumption in patients, especially for psychiatric patients. These are very interesting because it gives you the trace of everything that the subject has been consuming. Why? Because how do you consume? How do you reconsume? There is around 50 reasons, and the subject answers, and this is interesting because it means with the same type of scale, we can go directly to work on this with the patients, and this is very useful. This is my final slide now. When I feel stressed, when I want to do something, when I'm with friends, when I feel relaxed. And this tool is very useful for clinical practices to discuss and to engage the subjects in a dialogue, not necessarily to stop consumption, because if you say to them simply, you should stop, obviously the message won't get through. Thank you very much for your attention. Thank you, Alain. We have a few minutes now with lunchtime. Midday is our limit. If we have a few questions, we could finish this morning's session with these. Just one. Pierre. We can't hear the speaker. The speaker doesn't have a microphone. It depends on the case. It's case by case. There's no consensus on the subject. Nationally, it's considered the standard, the ATHS standard. There's a slide on which Alain has drawn our attention. If we have elements of vulnerability which increase the risk, they can be put on psychotic treatment. If the consumption is before the 15 years old, and perhaps something that wasn't signalled, It's the ratio of cannabis, cannabidiol to THC. When it's a titration. Quality is important, which have shown that when the ratio is balanced, the scales are better. So all of these are arguments for clinicians to move forward or not. These are guidelines. I don't think that things have to be prescribed. Are there any questions? George. Situation 1 and 2 are completely different. The first one is about someone who's paranoid, and the second one is not the case. This is do we leave them without treatment with the risk of schizophrenia? But as Alain said, we're on factors which are very important in terms of moving towards psychological disorders. An antipsychotic is not necessarily treatment for life. Its efficiency can be evaluated and reassessed. When they arrive at accident emergency, it's because the situation is very advanced. I have two observations. Firstly, on the bacteria on UHR, there was a very low doses of cannabis with a balanced ratio with cannabidiol, which enabled us to avoid transferring. It was a very interesting study for UHRs, and what Romain showed, the decoupling of dopamine and the shock scale. That's very typically linked to cannabis. And the second observation, what you just showed, Alain, it reminds me of a talk yesterday by OFDT on the on confinement, where there was experimenters would. I'd be interested to find out for the data that we're going to get from the OFDT if we've not got a second type for the future, because we have overall experience both in France and worldwide, and we need observations on what those who have increased their cannabis are going to see. Also, this raises another question. It's schizophrenia is a multifactorial complex disorder, and so the causalities are multi-factor. And we can see this where factors of stress, problems of young soldiers. We have a society which is evolving with a relationship with where there's also genetic vulnerabilities, traumatic childhood, and environmental factors, and the consumption of a substance, which favours the emergence of a disorder in a specific time frame. Perhaps we are substituting risk factors with other risk factors in the expression of this pathology. When you talked about factors due to stress, you talked about the army. We don't have military service anymore, but at the time, back then, we had the obligation for 90 days to see vulnerable people with very important BDs, and there was an intern, the syndrome of the essential child. And we had this notion of taking cannabis, which was making a lot of noise. And I remember people said no, and let them go back home, wait 90 days until a medical and a military decision is taken. But I think that's really is the clinical situation at the time. Thank you. You talked about the relationship of doses and effect. You didn't look at mode types of consumption of cannabis. Is the work still being done on this? Or do you have any extra information you could give? The big difficulty is to quantify. It's the subject of several editorials. It's very, very difficult to quantify this, for example, with cannabis. There's a standard order with tobacco, but for cannabis, this doesn't exist because for cannabis, all forms of cannabis are different. And then the way, and also especially the way in which it's consumed is important. If it's consumed by inhalation, it has higher rates of blood TCH, and machines with gas chromatography are very expensive. Then we can't quantify, and this is a huge problem internationally. It blocks research for us because we don't have any gold standard for the quantity of cannabis, because it's not so much the way you consume, it's the rate of THC in the blood. Work by the Indians in the 1970s, Chopra showed that by consuming, you had a very well described the trial by Al, who tried to get around the problem by saying that patients were their own witnesses. We can make everybody have a delirium. That's the conclusion of the work. There's the quality of the mechanism by which delirium is triggered, and we could also see people who already had predispositions to this. So you have to. The organic medium is visual. When you have a psychiatrist, as Pierre said, you need to decide whether you put them on psychotics or not. Two more minutes and then we stop. All the research that we can have on the quality of CBD available in France, what do you think of proposing it to subjects at risk? For example, this is all bullshit. We'll have to be very clear here. What is sold and the shops that are opening in certain places is no rice. The SM will have created a label to all patients, including all in the room. If people have allowed their THC, they will then say, do you encourage me to continue? I'm not going to say no, I'm going to be pragmatic. It's like, as Nicolas Ortiz said this morning, the first effect it perhaps will give you pleasure. I'm not sure what my colleagues think about this. When we're confronted with young consumers, the approach for reducing harm is obvious, it's pragmatic. So in the context of reducing harm, if there's cannabis is taken, why not? The advice, recommending it, I'm not sure whether we can actually recommend it yet. But in any case, we can see that in some subjects, they try to stop themselves because they don't want to end up being paranoid. It's not a very pleasant state to be in. So they also try to compensate and take it with very variable effects. I spoke at the last neurology conference, so I've tried to summarize the main points. There's a whole series of issues. Is it pure CBD? Because a lot of it contains 0.2% THC. Secondly, the level of proof is there's very little proof. It's not easy because you'd have to take this study and look at perhaps 10,000 people over several years and compare them to those who take cannabidiol. It would be very, very difficult to start this kind of research. It's just about C2NA. There's also often advertising with the orange form. So it may work. And all of this needs to be checked. Thank you, Alain. CBD is better with THC rather than just on its own. Thank you.
Merci, Amine.